when it comes to using MRD to guide decision making in myeloma right now, there are several key studies, that have already been published that tell us that MRD might actually be ready to use in that context. In the master trial that was published by Luciano Costa and colleagues, we see that in particular, patients were able to discontinue therapy at a rate of about almost 70 to 75% when they achieve 2 consecutive MRD negative tests by NGS at 10 to the minus 5. And we see that a large percentage of those patients still had not progressed. So, that's one piece to it. But one of the things that we noted in that trial is that patients with many high-risk abnormalities, certainly the ones with 2 or more, those are probably not the candidates that we want to take. So, we want to focus on standard risk patients and potentially one high-risk abnormality. There was also another recent study that came out by Dr. Rossignol and colleagues in Blood that looked at, it was actually designed to look at ixazomib, lenalidomide, and dexamethasone versus lenalidomide and dexamethasone as a maintenance therapy. And while there was no difference in terms of progression-free survival or even MRD negativity between the two arms, suggesting that ixazomib doesn't really add much to lenalidomide in the maintenance setting, what was interesting is that there was actually built into this study this idea that patients who were MRD negative could, after 2 years, discontinue therapy. And what I find really interesting about this study is that, we actually now have some longitudinal data directly derived from this study about what happens to patients if they discontinue with MRD negativity after 2 years. And what's really impressive is that the 4-year progression-free survival for those patients was 83%. This is not 4 years from starting therapy. This is 4 years from stopping therapy. So that means that, only 17% of patients who were MRD negative after 2 years of maintenance had disease progression. So I think this gives us more confidence that maybe we can, in fact, stop therapy. Especially for patients who have deep MRD negativity. I'm involved in a study at the University of Chicago called MRD to Stop, where patients who have sustained MRD negativity by NGS at 10 to the minus 6 can undergo discontinuation of maintenance. And while we still have, longer follow-up that's needed, we already reported that, approximately 85% of patients remain MRD negative, not just free of progression, but MRD negative within the first year of stopping therapy. And ultimately, we're going to be looking at 2 and 3 years on the study to be able to say what is the MRD negative free survival, the progression free survival, and overall survival for these patients. So I think we still have more data to come on this, but right now we're looking at, focusing on the discontinuation piece. I think the flip side is, what do you do for patients that never achieve MRD negativity? When they have persistent MRD positivity, is that a sign that we should be doing something else? Is the inevitable going to occur that is progression, or are some of these patients safe to continue off of therapy or don't need any escalation? That's a much thornier issue, and one that we're going to have to see what happens in the future.